Okay, I think we're going to go ahead and get started. Good afternoon, everybody, to Internal Medicine Grand Rounds for the Department of Internal Medicine. We have an outstanding speaker today. It's Dr. Maria Sevilla Alsina. Dr. Sevilla Alsina is an assistant professor in the Division of Diabetes and Endocrinology. Dr. Sevilla Alsina graduated from internal medicine residency in Ponce, where she also was chief resident. And then we were so incredibly lucky to have her come do her endocrinology fellowship here at USF under Joaquin Gomez-Daspet as program director. And she graduated in 2018. Dr. Sevilla Alsina, on their 5 years as faculty, has taken leadership initiatives. She is the head of the USF pituitary tumor from an endocrinologist standpoint, and has easily double digits publications, lectures, abstracts that she has given. She's an outstanding educator of our internal medicine residents and our endocrinology fellows. So we are very lucky today to have her presentation of a very important topic, adrenal incidentalomas. So we get that all the time in CT scan reports, MRI reports, and Dr. Maria Sevilla Alsina is going to guide us through the scientific method on how to deal with these. So with that, I will turn it over to you, and we're in for a treat. Thank you so much.
Thank you so much, Dr. Lezama, for the introduction. I appreciate. Can you hear me well and see my presentation, right? Without problems?
Looks good.
Okay, thank you, Jennifer. So good afternoon, everyone. We are going to discuss adrenal incidentalomas. I chose this topic because I think that after diabetes and after thyroid problems, this is one of the most frequent encounters that internal medicine can see, and also endocrinology. So today I'm going to try to focus more on the workup that typically I think that sometimes we have some maybe questions about the biochemical workup and the radiological workup. So you are going to see that in my presentation, I'm going to be talking in more details about that. So let's move forward. The objectives for this presentation, we are going to talk about the prevalence. We are going to discuss the evaluation of for hormonal secretion. We are going to describe imaging phenotype of benign adenomas, the characteristics when we are talking about malignancy, and we are going also to discuss the management of adrenal incidentalomas. Adrenal incidentalomas are a common endocrine diagnosis, and it's going to affect around 2% of the population. And nowadays, it's one of the most common unexpected findings that we are going to see in imaging studies, in CT, MRIs, or ultrasound. We can see in around 4% of the patients that we order imaging studies for a non-adrenal disease that we can detect adrenal incidentalomas. And around 10 to 15% of the patient with adrenal incidentaloma, they are going to have an autonomous excess of hormonal secretion from the adrenal hormones. So it's going to be very important that we do a multidisciplinary approach so we can do an effective management for these patients. The prevalence is going to increase with age. It's going to be higher in patients with obesity, patients with diabetes, and patients with high blood pressure. The peak incidence is going to be around age 50 and 70. And it's rare that we see patients with adrenal incidentalomas with age lower than 30. So if we have a patient with an adrenal incidentaloma that it's age 30 or less, we should do workup for adrenal carcinoma, and we should do workup for hypersecretion of the adrenal hormones. The frequency from males and females is going to be the same, and we can do detection of the adrenal incidentalomas with CT scan. Depending on the publication, we can see that it's around 1.4 to 7.3%. So it's going to be important to briefly review the adrenal embryology, anatomy, and physiology of the adrenal glands so we can appreciate the significance of adrenal incidentalomas and the treatment. The adrenal glands, they have a pyramidal structure. The weight is going to be around 4 grams. They have a very high vascularity. They receive a blood supply from the superior, from the middle, and the inferior suprarenal arteries. And that's the reason for the predilection of cancer metastasis. And also the adrenal glands can be susceptible for non-traumatic adrenal hemorrhage. They have also a numerous vein drainage variations, and this is going to be important for the surgeons when they are going to do adrenalectomies, and also for the interventional radiologists when they are going to do the adrenal venous sampling. In terms of the embryology, the adrenal glands are going to derive from two distinctive embryologic organs. We are going to have the cortex that is going to come from the mesoderm of the urogenital ridge, and the medulla that is going to come from the neural crest cell, the neuroectoderm. And the fetal adrenal glands are going to be evident from around week 6 to 8 of gestation. And interesting, they are gonna grow rapidly. And during mid-gestation, they can be larger than the kidneys. The adrenal cortex, they are gonna differentiate fully into the 3 zones around age 3. And then when we are evaluating the cortex from the zona glomerulosa, we are going to have the production of aldosterone, and the zona glomerulosa is going to represent around 15% of the mass cortex. The zona glomerulosa is going to be controlled by the angiotensin II and the extracellular potassium. And the production of aldosterone is going to vary depending on the salt intake. We know that the action of aldosterone is that it's going to increase the absorption of sodium, is going to increase the excretion of potassium and hydrogen. What about the zona fasciculata? Is the one that is going to produce the glucocorticoids, and it represents around 75% of the mass cortex. The secretion is going to depend on if we are on a physiologic stress, but the normal daily amount is going to be between 10 to 20 milligrams per day. And it's going to be controlled by the hypothalamus pituitary adrenal axis. The glucocorticoids, they are going to facilitate the release of energy from the fats, from the proteins, from the carbohydrates, for us to utilize this energy during stress. And then we have the zona reticularis, that is the one that is going to produce the adrenal androgens, and it represents around 10% of the mass of the cortex. This zona is going to produce the DHA, DHAS, and the androstenedione. So, and what about the medulla? The medulla is the one that is going to contain the chromaffin cells that are located in the adrenal glands, but also they are going to be located in the sympathetic paraganglia nervous system. And the chromaffin cells are the responsibles of the production of the catecholamines. So what is an adrenal incidentaloma? Adrenal incidentaloma is going to be defined by an adrenal mass that is greater than 1 centimeter. Okay, so it's important that we have that number in mind. And we are going to detect this adrenal mass when we are ordering imaging study, a CAT scan, an ultrasound, or an MRI for not adrenal disease issue. The current guidelines, they don't recommend that we do biochemical workup for an adrenal mass that is lower than 1 centimeter. But there's an exception. If we see that this patient clinically have an indication to do the biochemical workup and to do further workup, then we do it. But if not, then more than 1 centimeter is that we are going to proceed to do the full workup. And the etiology of the adrenal incidentaloma is going to be variable. It includes tumors from the adrenal cortex, the adrenal medulla, and metastatic lesions. There's two important questions that we have to have in mind when we are evaluating an adrenal incidentaloma. Is this a malignant tumor, or is this a tumor that is secreting excess of one of the hormones from the adrenal glands? And then when we are talking about adrenal tumors, the most common tumors that we're going to see are going to be benign tumors. This is a study from Mayo Clinic, the Rochester Epidemiology Project, that they evaluated patients with adrenal tumors that they were diagnosed from 1995 to 2017, and they found that 90% of these tumors were adrenal tumors that were benign. 9% of these tumors were malignant masses, and the majority of these tumors were metastatic lesions. And then 1% were tumors that were pheochromocytomas. And then while the most incidentalomas, they are adrenal adenomas, and we have the majority are non-secretory adrenal adenomas. Some of them, they are going to produce excess of glucocorticoid, mineralocorticoids, and more rare, they are going to produce androgens or estrogens that are going to result in virilization or feminization. We can have other tumors as, for example, myelolipomas, amartomas, granulomatous infiltration of the adrenal glands, and we can have adrenal carcinomas and adrenal metastases. Something that is important is that we need to have a good evaluation radiologically, and I'm going to present what are the features for the benign versus the malignant lesions, but the radiological workup can help us at least to differentiate between a benign and malignant lesion. We can also see bilateral adrenocortical tumors, and they are going to represent around 10 to 50% of the cases. We can see metastasis, primary bilateral macronodular adrenal hyperplasia, bilateral pheochromocytomas that they represent around 10% of the pheos, infiltrative disease, congenital adrenal hyperplasia, amyloidosis, infections as, for example, TB or fungal infections, bilateral cortical adenomas, and Cushing disease or ectopic ACTH secretion with secondary bilateral hyperplasia. And from the tumors from the adrenal medulla, we know that they are going to secrete catecholamines. They can be benign or malignant, and typically they are going to occur at age 40 to 50. But something that is important with these type of tumors is that 40% of the cases, they can be associated with hereditary syndrome. And most common BHL, von Hippel-Lindau, MEN type 2, or neurofibromatosis type 1. All of them, they are autosomal dominant. And when we have patients with pheochromocytoma, it's going to be also important to have that genetic evaluation. So let's just review the workup that we are going to order for adrenal incidentalomas. It's going to be divided in the radiologic evaluation and the biochemical hormonal evaluation. With the radiological workup, what we have to have in mind is that the imaging phenotype is not going to predict the hormonal function, but it may be helpful. To differentiate benign versus malignant tumors. So let's review the features of each of the most common adrenal tumors. For benign adenomas, what we are going to see, it's typically around a homogeneous and a smooth tumor. The size of this tumor are going to be typically lower than 4 centimeters. They usually have a unilateral location. And when we are ordering an enhanced CT scan, the Hounsfield units are going to be lower than 10. Just to review what is a Hounsfield unit, Hounsfield units is a measure of the radio density. So black is less dense. And then when we use a threshold of 10 for the Hounsfield units, this is very specific, has a very high specificity for adenomas that is around 98%. Also, we can check the washout with contrast, and for benign adenomas, the washout is going to be more than 50% for the benign tumors. We can also, in some circumstances, we can also check the MRI, and MRI, they are very good with the lipid characterization. What about pheochromocytomas? These tumors are going to have elevated Hounsfield units, more than 10, typically more than 20, and they are going to have a high vascularity. They can have cystic portion, they can have hemorrhagic changes, and also the size can be variable, and they can be bilateral around 10% of the cases. And what about adrenocortical carcinomas? They are going to have irregular shapes. They can have calcifications. The size of the tumor typically is going to be more than 4 centimeters, typically unilateral location. Hounsfield units are going to be elevated, more than 20. And even that the CAT scan is our preferred first imaging study. Sometimes if we have an inconclusive report, or if we have suspicious for malignancy, then we can use other imaging studies, for example, the PET-CT scan or the MRI. If we are suspecting malignancy, further investigation may be required. Let's just review again the characteristics on the CT scan. Size for malignancy, typically more than 4 centimeters, heterogeneous. There can be high vascularity, Hounsfield units more than 10. But then sometimes we may need further investigation. We can use an MRI with chemical shift. That is a very sensitive, non-invasive method to differentiate adrenal adenomas from metastasis. And it is often used when the CT findings are classified as indeterminate. The chemical shift MRI is going to rely on detecting intracellular lipid in the adenomas. So if we have a signal that drop or loss in the T1 out of phase, that means presence of intracellular fat. Another excellent study that we can use is the PET-CT scan. And when we have an adrenal mass that is showing an uptake lower than the liver, then we consider this mass as a benign lesion. And the sensitivity for this study is around 91%. Let's review the biochemical workup. When we have an incidental adrenal mass, always we have to check for hypercortisolism. And the 1 milligram dexamethasone test is considered the most valuable test for adrenal incidentalomas and the evaluation of hypercortisolism. The cutoff that we use is 1.8. So if we have a result that is lower than 1.8, that rule out hypercortisolism. Also, we like to order DHA-S, that in these cases, if we have hypercortisolism, it's going to be low. Why? Because we are going to have also a suppression of the ACTH that it control the production of cortisol and also can control the production of DHA-S. If we have a CAT scan on enhanced CT scan that the Hounsfield units are more than 10, we need to check workup for pheochromocytoma. And we can order a 24-hour urine collection for metanephrines or plasma metanephrines. And if we have a patient with adrenal incidentaloma that has high blood pressure or hypokalemia, we also need to check for primary hyperaldosteronism. And the main test that we're going to order, and we'll see it later, is the aldosterone and plasma renin. Some of the adrenal incidentalomas can cause abnormal hormone secretion without obvious clinical manifestation. And the most common presentation for this situation is going to be the mild autonomous cortical secretion. Before, this was named subclinical Cushing. This is the most frequent hormonal abnormality in patients with adrenal incidentaloma, and it's going to represent around 20 to 30% of the cases. As we mentioned before, the best test biochemically to define this phenomenon is going to be the 1 milligram dexamethasone test. We are going to also to see a low ACTH and a low DHS that is going to be less than 40 micrograms per deciliter. And then there's some studies that they have mentioned that if we have a DHS that is more than 100 and an ACTH that is more than 15, this is going to exclude the mild autonomous cortical secretion. These patients, they can have risk for cardiovascular disease. They can have risk for diabetes, obesity, and metabolic bone disease. And then the treatment, we need to have a very good conversation with the patient. We have to evaluate what are the risks that these patients are having, and then make a decision about observation versus surgical approach versus medical therapy. If we have a patient that is going to, we think that is going to be a risk to have cardiovascular disease, of a patient that have cardiovascular disease, surgery approach is going to be the best management. Why? Because it's the only therapy that we have that is going to decrease the risk for cardiovascular problems. With Cushing syndrome, the biochemical workup is going to be pretty the same that the mild autonomous and hypercortisolism, But what I want to show here is that if we have a 1 milligram dexamethasone test that is positive, we have to do more biochemical workup. And we need to have at least 2 to 3 of the workup that we have for hypercortisolism positive. So which are the options that we have? We have 24-hour urine collection for cortisol. We have the late night salivary cortisol and the 1 milligram dexamethasone. So if we are going to choose the urine collection, or if we are going to choose the late night salivary cortisol, then we need to do 2 samples. For the saliva, at least 2 samples for the saliva or for the 24-hour urine collection. But that's something that is important to know. If these tests are positive, then we are going to check an ACTH level. And for patients that have Cushing syndrome, what we are going to expect is to see a low ACTH, and that is telling us that the hypercortisolism is coming from the adrenal glands. Sometimes we have special populations that we need to make sure what can be the best test for evaluation for hypercortisolism. Why? Because it can, in some populations, we can have increase for false positive or for false negative. So let's review the options that we have. For the 24-hour urine collection for cortisol, as we discussed, we need 2 measures. It can be a good test for evaluation in patients that are pregnant. Also for patients that have cyclic Cushing syndrome. It is not a good test, as probably you can imagine, for patients that have renal failure or for patients that have mild autonomous cortical secretion. We have seen patients with mild autonomous cortical secretion that the 24-hour urine collection repeated once, 2 times, it's normal. And then we have a 1 milligram dexamethasone that is more than 1.8, a low ACTH, a low DHAS. For the 1 milligram overnight dexamethasone, indications, we can use it as we discussed for adrenal incidentalomas, for mild autonomous cortical secretion, for renal failure. Is not a good test for pregnant patients or patients that are taking estrogen or patients that are taking medications that can increase the cortisol binding globulin. Why? Because we can have a false positive. For the midnight salivary test, we need at least 2 measures. It can be a test that we can use it for patients that are taking anti-epileptic drugs, for patients that have mild autonomous cortical secretion, for patients that have cyclic Cushing syndrome, not a good test for patients that have night shift jobs. So let's talk a little bit about aldosteronomas. They are going to represent around less than 1% of the adrenal incidentalomas. And we are going to order workup if we have a patient that have history of high blood pressure, hypokalemia. And the first test that we are going to order is the plasma renin and the plasma aldosterone. We typically recommend to order the plasma renin and plasma aldosterone separately instead of the option that probably you may see in EPIC that is the ratio that you can order, like ratio for aldosterone and plasma renin. So we prefer like to order both separately and then do the calculation. It's going to be important to let the patient know to go in the morning on fasting around 8 a.m. for the blood collection. And then the plasma renin, we are going to see levels lower than 1 nanogram per milliliter per hour. And the aldosterone typically is going to be more than 10. And when we do the ratio is going to be more than 20. And that is going to be suspicious then for primary hyperaldosteronism. So low renin, high aldosterone, high suspicious for primary hyperaldosteronism. Most common cause is unilateral, but also we can have bilateral disease, and also we can have hereditary disorders that are associated with primary hyperaldosteronism. One of the most common questions that that also us as an endocrinologist, and also I know that internal medicine may have, is, are we going to check the plasma renin and plasma aldosterone with all the antihypertensive medications that the patients are taking? So nowadays, the research and literature, they recommend that we can check plasma aldosterone and plasma renin with all the antihypertensive medications that the patients are taking. But what happened with the mineralocorticoid receptor antagonist? That is like one of the most common questions. What the mineralocorticoid receptor antagonists are going to do? So these drugs, we know that they are going to prevent the aldosterone to activate the receptors, and then this is going to increase the loss of sodium, the decrease in plasma volume, and then we're going to have an elevation of plasma renin. So for this reason, if the patient is not taking the spironolactone and eplerenone, we recommend not to initiate these medications until we complete the workup for primary hyperaldosteronism. But if the patient is using mineralocorticoid receptor antagonists, we know that the data may be difficult to interpret, but we're going to have an exception to this rule, and it's the one that I put it in the slide, that if we have a patient that has hypokalemia, despite the use of mineralocorticoid receptor antagonists, then the mineralocorticoid receptors are not fully blocked. And then the plasma renin or the plasma renin concentration should remain suppressed in patients with hyperaldosteronism. And then we can use these results and then proceed with the next step that we're going to have for primary hyperaldosteronism workup. Let's review one of the cases from our clinic because it has a detail that I think that is going to be important for all of us regarding the primary hyperaldosteronism workup. So this is a female, 26-year-old female with history of high blood pressure and severe hypokalemia for the last 2 years. Multiple visits to the ER due to low potassium. I put it the 2.5 because usually when she was going to the emergency, that was the range of the potassium. And you can see the blood pressure, very high blood pressure, 180/100. The patient, she continued having severe hypokalemia despite high doses of potassium supplementation. When we saw her in the clinic, she had already plasma aldosterone and renin that was checked. And you can see that the aldosterone, the level was 8 and the plasma renin 0.39. So the patient was told about the low concern for primary hyperaldosteronism because the aldosterone was lower than 10. But then when we were reviewing the laboratories and the way that the plasma aldosterone and plasma renin was taken, we saw that the potassium level was very low, was 2.5. So something that is important when we are ordering the plasma aldosterone and plasma renin is that we need to make sure to replace that potassium and aggressively replace the potassium and try to get the potassium around over 4. So let's see. So we recommended to repeat the laboratories while the patient was normocalemic. And the aldosterone, you can see big difference on the aldosterone before was 8, and then aldosterone now 33 with a plasma renin that was 1 nanogram per milliliter per hour. We also checked for Pheochromocytoma and hypercortisolism. We didn't order the 1 milligram dexamethasone because this patient was taking estrogen replacement. And then the CT scan, you can see a 1.3 centimeter right adrenal nodule with a Hounsfield unit -9 and a washout more than 50%. Then there's some exceptions for confirmatory tests. And you're gonna see it here and then in the next slide. So if we have a patient that have a spontaneous hypokalemia as this patient and a low plasma renin, and an elevated aldosterone more than 20, or if we have a patient with a low plasma renin or aldosterone more than 30, you don't need to do confirmatory testing for primary hyperaldosteronism because there's no other cause. So you don't need to do saline suppression tests or sodium loading tests. You can then proceed with imaging studies. So we ordered an adrenal venous sampling, and what I want that you see here is just the aldosterone in the right adrenal gland. We do calculations once we have all the results, but you can see that the aldosterone in the right adrenal gland was pretty elevated. And then we confirmed that there was a lateralization to the right adrenal gland, and this favored the unilateral disease. So this patient, she had right adrenalectomy that was performed at PGH. And then after 2 weeks, the potassium level normalized and the replacement of potassium was discontinued, as well all the antihypertensive medications that she was taking. She was taking around like 4 antihypertensive medications. So we have a patient with an adrenal incidentaloma, high blood pressure, make sure to check the aldosterone and renin, and then to do confirmatory tests, except the exceptions that I put here and also in the previous slide, that we don't need to do the confirmatory test. Then we are going to order an adrenal CAT scan, and then we are going to check an adrenal venous sampling. If we have a unilateral primary hyperaldosteronism, a unilateral adenoma, and the patient is a good candidate for surgery, the main therapy is going to be surgery. If we don't have a patient that is a good candidate or is not interested in surgery, then we are going to proceed to start mineralocorticoid receptor antagonists. And if we have a bilateral disease, we need to treat the patient with mineralocorticoid receptor antagonists. This is a 44-year-old male with history of high blood pressure and around 8 years. History of palpitation for the last 16 to 7 years, occasional diaphoresis, anxiety, and weight loss around 20 pounds during the last months, no headaches. What I just want that you see here in the laboratories, you can see that the metanephrines, normethanephrine's, total metanephrines were pretty high, more than 2-3 times higher than the normal limits. And you can see the image. We have a 10.6 centimeter right adrenal mass that also have cystic and calcifications, very large adrenal mass in the right adrenal gland. We started the patient on medical therapy to prepare him for surgery, first with alpha beta blockers, followed by beta blockers. And then when the patient was prepared for surgery, he had a right open adrenalectomy because we were talking about a very large mass. And what I want that you see here later is that we checked 1 week after the 24-hour urine collection for metanephrines, and all the laboratories were within normal limits. This is a patient that right now he's not on antihypertensive medications. So when we are talking about pheochromocytomas and adrenal incidentalomas, they represent around 1 to 3% of the adrenal incidentalomas. For patients that are going to be very symptomatic, so typically these are the patients that have a very large mass, as for example, the patient that I presented. Around 50% of the cases are going to have the symptoms that we know about paroxysmal symptoms, the sweating, the headaches, the tachycardia. But what happened nowadays? Nowadays, we can have some pheochromocytomas that can be discovered in the pre-symptomatic stage. Usually, these are smaller tumors around 1.5 centimeters, and sometimes they can have normal biochemical testing. Other symptoms that the patient with pheochromocytoma can have include tremors, weakness, palpitations, anxiety, constipation, polyuria, or polydipsia. And there's some tumors that rarely that secrete epinephrine that patient can have instead of hypertension, can have hypotension. About the biochemical testing for pheochromocytoma and adrenal incidentaloma, if we have a patient that the CAT scan shows a Hounsfield unit more than 10, then we are going to proceed to check for pheochromocytoma. The average of the Hounsfield units are going to be between 30 to 35. We have the option to check for with plasma metanephrines or to check with urine metanephrines. There's some publication that says that if you have a high suspicious, that you can use plasma metanephrines as a first option, low suspicious urine metanephrines, but both they have good sensitivity around 90 to 95%. One of the most common questions when we are doing the biochemical workup is, do we have to stop any of the medications that the patients are taking to decrease the risk of false positives? So it's very important that when you are ordering the workup for pheochromocytoma, take a look on the medications. and evaluate the medications with the patients. If you see that the patient is taking a medication that can increase the level of catecholamines, then have the discussion with the patient. If it is, for example, an antipsychotic medication or a medication that you don't feel comfortable holding the medication, then evaluate with the psychiatrist of the patient and then hold the medication at least for 2 weeks and then do the workup. When you are ordering the plasma metanephrines, you have to let the patient know that it's going to be important that the blood drawn can be taken after resting in a supine position at least for 30 minutes. If you have elevated metanephrines, more than 2 times higher, pheochromocytoma is likely, then you are going to proceed with imaging studies. If you can visualize a tumor, then you are going to start preoperative medication, alpha blocker, followed by beta blockers. Consider also the genetic evaluation, and then you are going to go for surgery. If the metanephrines are elevated, that we know more than 2 times higher, pheochromocytoma likely, imaging studies, but you don't visualize the tumor, then we know that we have other imaging studies available that we can use as the DOTE test, the PET CT scan, the MIBG. And then if you visualize the tumor, you are going to start medical therapy, and then treatment is going to be surgery. What about adrenal metastasis? We know that the adrenal glands, they have a high blood supply, so the adrenal glands can be a risk to have adrenal metastasis. Around 90% of the metastatic gland lesions are going to be carcinomas. We can also see hematologic sarcomas or melanomas, but the most common are going to be carcinomas. And from the carcinomas, the most common side is going to be from the lung, around 35%, followed by GI, kidney, and breast. We can also see bilateral adrenal involvement, and this is going to be around 50%. And patients with non-Hodgkin lymphoma, they can also be a risk to have adrenal gland involvement, and this is going to be around 25%. It's more rare, primary adrenal lymphomas, and it's around 1% of the cases. And with adrenal carcinoma, they're going to represent around 2 to 5% of the cases of adrenal incidentaloma. The size is going to be more than 4 centimeters in the 90% of the cases. And typically, we are going to have like one or two or maybe more secretion of the adrenal gland hormones. So if there is evidence of hypersecretion from 2 adrenal zones, this is highly suggestive of adrenal carcinoma. And most commonly, it's going to be excess of cortisol, around 45% of the cases. And then we can also have around 10% excess of androgen. And what about the fine needle aspiration biopsy? So what we need to know is that this is not going to distinguish a benign cortisol adrenal mass from a less common adrenal carcinoma. So it can differentiate between the adrenal tumors and metastatic tumors. But something that is important if we need it is that we have to rule out first pheochromocytoma. And then this is my last slide. That I think that it's very helpful when we are evaluating a patient with adrenal incidentaloma. So if you have an adrenal incidentaloma that you are evaluating, please have this reference. This is from UpToDate, but have this reference then to guide you. So if you have an adrenal incidentaloma, you have to evaluate for hormonal secretion. First test, you are going to check for hypercortisolism, and we discussed what are the main tests that we're going to use. That is the 1 milligram dexamethasone and the DHAS. If we have adrenal mass that the Hounsfield units is more than 10, we are going to check workup for pheochromocytoma. If we have a patient that has an adrenal incidentaloma with high blood pressure and low potassium, then we are going to check for primary hyperaldosteronism. And then if these tests are positive, we are going to do confirmatory tests. If the confirmatory test is positive, we are going to consider surgery. If the confirmatory test is negative, then we are going to check the imaging phenotype. And if the harmful units are lower than 10, then we are talking about a benign imaging phenotype, and we can repeat the imaging studies in 12 months. And then the workup for hypercortisolism, we can do it every year up to 4 years. If the progression is suggests, because we have an incidentaloma that has grown more than 4 centimeters, or a growth of more than 1 centimeter, or if the adrenal incidentaloma is developing hormonal autonomy and hypersecretion, then we consider this progression at any time, and we should consider surgery. If we have a progression-free at 4 years, then this is unlikely that these tumors are going to develop hypersecretion of any of the hormones, and then no further follow-up is required. If we have a CT scan that is showing us a Hounsfield unit that is more than 10, then this is a suspicious for malignancy, and then we can consider or to do surgery or to do a biopsy or close follow-up with imaging studies in 3 months or 3 or 6 months. I think that this is my last slide. So if you have any question, we are here, and thank you so much for allowing me to present this topic in the internal medicine ground round.
Thank you very much, Dr. Sevilla. Alsina, outstanding job. We'll take any questions from endocrinologists and non-endocrinologists. Both are fair game. Go ahead and ask your questions. We have a lot of applause going on there. Dr. Gomez-Daspet, is he on? I'm sure he has a question.
Go ahead and take the mic, Dr. Gomez-Daspet.
Can you hear me now?
We can hear you.
We can hear you in your incredible Spanish accent. That is beautiful. Go ahead.
Same than me.
Yeah. First, thank you for the presentation. It was very nice and very appropriate for the audience. You really present in an understanding manner an approach to the adrenal incidentaloma. No? I am going to make two comments. One of the comments is that for the new generation that to understand a switch in the paradigm. I remember in the 80s, I have been practicing for so long. Often we will make the diagnosis of Cushing syndrome, like you read in the book, no? Patient with proximal muscle weakness, plethora in the face, weighting in the extremity, purple stria, supraclavicular fat, central obesity. Nowadays, we make diagnosis more common and more common without that symptom because the patient have an incidental adrenal mass. Same thing with hyperpara. I remember making diagnosis of hyperpara patient with hypercalcemia, a kidney stone, cystic osteodystrophy, or brown tumors. Nowadays, we made the diagnosis of hyperpara, sometimes even with normal calcemia. Then probably the new generation should be aware that more and more we're making those diagnoses in patients with pre-symptomatic stages. Then in a patient with an adrenal finding, I should recommend sometimes we may need to do the workup because we are detecting in a preclinical phase or stage. My last comment for the audience is to be aware that when the patient have bilateral tumor, we also need to rule out adrenal insufficiency. And the reason I am going to mention that is because still with all the changes in technology and science, some of the principles from endocrinology still persist. And one of the principles is, if you have a hyperfunction, you suppress to make the diagnosis. If you have a hypofunction, you stimulate to make the diagnosis, meaning that if you have a patient with a bilateral masses and you rule out hyperfunction, you may need to do a special testing that is different to be sure that the patient doesn't have AI. That will be a CTH stimulation test, because you do the workout, the workup for hyperfunction, and there is a possibility that the patient may have AI, adrenal insufficiency, because they have a bilateral mass that could be metastatic disease. Then it's important that you understand that you need to do a different test to diagnosis AI that could be ACTH STIM test. Thank you.
Thank you, Dr. Gomez, for the comments. Thank you so much.
That was
Thank
an
you.
excellent presentation, Dr. Sevilla.
He's a proud program director. So, all right, next is that Dr. Ramirez.
Yeah, that was me. But I also wanted to invite Jeffrey Douglas, who raised both hands to ask a question, and we haven't given the opportunity to speak.
Okay, absolutely. Please go ahead with the question.
Hello, I'm on the acute care surgery service. I actually typed up the question, but I'll say it here. So we encounter a decent amount of incidentalomas in workup for trauma or emergency general surgery issues. Many of these patients don't need to stay in the hospital beyond 24 hours for their trauma or EGS issues. Do you recommend that we keep them, delay their discharge to do this workup? Or is there some place that they can go? This is not a workup that we can do. We're not set up to do this type of workup as like in our clinics. So what is your recommendation for those patients that are young, don't have a primary care provider, they're forced to interact with us because of their trauma? It's not like they chose to come, and we find this incidentaloma.
Yeah, that's a great question. I think that best way will be to refer the patient to us, and then we can do the workup in the outpatient. And best way to do this workup is like when the patient is not, very acutely ill, right? To avoid the risk of unreliable results. So I think that if there's not a concern of like that this tumor and it's like causing any acute problem, then we should see this patient in the outpatient in our clinics. How often do you see these encounters?
It's probably 2 or 3 times a year, but there's always that, question of, well, what do we do? Who's responsible for that new diagnosis? It's not the only, we find, non-trauma related diagnoses pretty frequently, but the adrenal incidentaloma is probably 2 or 3 times a year.
Mm-hmm. It's the same. We also have seen more pituitary microadenomas, and also there's a question about like if this patient needs workup. So the same, if in the hospital you see these incidentalomas, I think that best way, we're talking more than 1 centimeter, like for us to see the patient in the clinic.
Thanks.
And I would like to make another comment, Dr. Sevilla. Again, thank you for your nice presentation. Remember that probably 85 to 90% of the patients with adrenal mass are going to be non-functioning. Then probably it's a low probability of the diagnosis, but in the case that the patient is admitted, it would be nice to assess for any concerning symptom. But in most cases, we prefer to do the workup as outpatient because during the inpatient setting, you can have false results. I am going to make unclear one big exception. In the case of trauma, if you have bilateral adrenal hemorrhage, in that case, probably we need to rule out AI before the patient is at home, because it could be life-threatening condition. Then, if the patient with a trauma, what you see in the adrenal is bilateral adrenal hemorrhage, that probably it will be prudent to consult endocrinology or at least do ACTH STIM test before the patient is sent home.
Understood.
Dr. Kusheva?
Yes, thank you so much, Dr. Sevilla. It was phenomenal presentation. Thank you so much. So I have kind of like a comment here because I started seeing more and more patients with adrenal adenomas because Tampa General Hospital introduced quite recently, I don't know exactly when, the program for former or current smokers with low dose chest CT. And of course, you can see adrenal glands on this low dose chest CT. And those patients usually sometimes there is basically no follow-up for those patients as well. And number of patients there is quite high. And of course, it would be absolutely appropriate, most likely to have a Tampa General protocol, what to do in situations like this. Just incidentaloma, more than, let's say, the nodule that was found during the screening test that is more than 1 centimeter, what we are going to do in this situation, because the chance that patient will go into clinic for one of the endocrinologists very quickly is very slim. You know, we have not enough endocrinologists in our area, definitely, and the waiting list can be very, very long. And I think this is something that would be very helpful, including this question from Dr. Douglas, what to do if they see this adrenal nodule. I would worry about, of course, if patient doesn't have pheochromocytoma, because it can be very life-threatening during the surgical procedures they are going to do. But this general protocol could help every single service who can see incidental finding in adrenals, something like adrenal adenoma, and plus young people, because this can be part of syndromic disorder, so adrenal nodule. So this is just my comment. And again, Dr. Sevilla, thank you. It was fantastic.
Thank you. And that's a great idea, Dr. Kushayeva. I think that to work on a protocol for TGH will be great. Thank you for adding that idea.
Well, let me take this quick opportunity, Dr. Sevilla. This is Alex Ramirez. What an excellent presentation, really phenomenal, great slides as well. I just wanted to ask you a question that kind of is always in the back of our minds, because it's not an easy topic, which is that of our patients with the lipid poor little mass, right? Usually a tumor that is maybe 1.5 to maybe 3.5 centimeters. It's found incidentally, Hounsfield units of around, say, 15 or 20. Everybody's scratching their heads. The radiologists may call it lipid poor adenoma. You know, adenoma really is a pathologic diagnosis, but occasionally the radiologists will call those adenomas. And that often gives perhaps a hint of reassurance to those physicians who read those reports and to those patients who are reading those reports themselves. But in reality, some of those may actually be quite a mine in which we may overstep and cause potentially a problem or see some complications there, as we potentially could miss a metastasis or a primary tumor. And I know you showed that last slide, but anyway, I wanted to hear you comment on those lipid poor masses.
I think that we need to, make sure, maybe if we don't feel comfortable, like have a discussion also with the radiology team, right? And then also if we have, as I mentioned in one of the slides, inconclusive or indeterminate, or then like to make a decision if we need more workup, radiologic workup, and also biochemical workup. So sometimes I have seen patients that they have an adrenal incidentaloma, reports that they have been diagnosed like 1 year ago and no one have done any work, right? And then when you see those lipid poor lesions, or when you see elevated Hounsfield units, then what is going to be your next step, right? So the evaluation of the patient, making sure that ask the patient about like conditions that the patient have, do a good physical exam, and then make a decision if we need further radiologic or a biochemical workup.
And how aggressive do you think, as a follow-up to that answer, how aggressive do you think we should be maybe sending more of those patients to get surgery? Like after we have completed our initial tests, how often do you think we should be sending those for adrenalectomy when we see a tumor that is, again, 1.5 to 3.5 centimeters? Thank you.
Yeah, it's controversial, right? But we have to see with the patient, have an evaluation. I saw a patient last year that she had a mild autonomous hypercortisolism, and then she wanted everything, right? She wanted, like, if it is surgery, what I have to do, I'm gonna do it, right? So I think that we have to involve the patient, and then if we don't feel comfortable with what we see on the images, if we have a young patient that maybe does not have contraindication for surgery, I don't see that is, I don't think that is a bad idea to involve or to consider surgery, right? And at least to send the patient to the urologist and have an evaluation and then make the decision, right? Because sometimes for the patient and sometimes for us, when we see these type of presentations, if we don't feel comfortable, and if we think that if we don't offer treatment, maybe in the future we can have complications, I think that is a good idea to make a decision about treatment and surgery, right? In the algorithm that I showed, you can also make the decision with the patient about like close follow-up. And to repeat an imaging study maybe in 3 months or 6 months, and then compare with the previous one, right? And I think that also that can be helpful to evaluate if we have a stable adrenal incidentaloma, if the characteristics of the tumor have changed, and then have a reevaluation again.
Excellent, thank you. I see that Dr. Bartz also has a question. I'm sorry.
Thanks, Dr. Ramirez. Dr. Sevilla, really great talk.
Thank you.
Just to kind of piggyback off of this discussion regarding, indeterminate and lipid poor adenomas, with discussion of other surgeons who are doing adrenalectomies for some of these smaller indeterminate nodules, a number of these surgeons have reported that they end up pathologically being pheochromocytomas. And so I think a lot of the literature is coming out of Mayo because they do a lot of adrenalectomies there. But there is a group of quote, young endocrine surgeons who kind of share ideas through social media. And there was recently a post on this. And I would say almost 10 of us have had the experience where these indeterminate nodules in patients that biochemically do not have a pheochromocytoma, after their nodules come out, they pathologically are diagnosed with pheochromocytoma. So certainly something to think about.
Yeah, that's a great comment, and we have seen more, as you said, pheochromocytomas that are not the typical cases as the one that I presented of this 10.6 centimeter pheochromocytoma. And nowadays, and now that we have more access to imaging studies, we can see these indeterminate tumors as 1.5, 2 centimeters that biochemically they are not present elevation on the catecholamines, and then they can turn, or they can be pheochromocytoma.
If you allow me a quick comment there, I would say the following, which is, you said, 5% or so of these tumors, of these indeterminate nodules, are going to be malignant primary. They're going to be 5% malignant metastatic, and 5% will be Pheos. So, there's going to be a relatively high number, 15% of them that will be determined. And yes, exactly as you said, Dr. Sevilla, all that workup, and like Dr. Bart's commented as well, you're going to find a relatively high number of positives after you do surgeries. Now, Dr. Gomez-Daspet has another question or follow-up, so please.
I was trying to clarify to the audience, to the resident and the fellow, the question that Dr. Ramirez formulated is very interesting, and it's very difficult and it's challenging for all of us, including the attending, no? And probably I'm going to give you an approach based on wisdom that is going to work most of the time. And what would be the approach? The question was that Dr. Ramirez is a patient that have a certain radiologic finding that is not conclusive, no, lipid poor, lipid rich, the Hanfield unit, but the patient was probably is non-functional. If the patient is functional, you're going to need surgery. What about if it's non-functional? What would be the ideal approach? Multidisciplinary approach, like a tumor board approach. You invite a radiology with expertise in adrenal. You may need further testing. You may need an MRI of the adrenal. You may need to do a CT with the adrenal protocol. And you invite a surgeon with expertise in adrenal surgery. And invite the patient. No, you usually do that. You involve radiology. You involve a surgeon. And the patient in the decision making, most of the time, you're going to arrive to the best decision based on the information you have.
Thank you for those comments, Dr. Gomez. And that's a great segue for plugging in our recently created adrenal tumor board that will be starting at the James A. Haley BSR next month. So Dr. Talera has a question. Please go ahead and unmute yourself.
Thank you. Thank you, doctor, for the presentation. I have a question. I don't know if you know the answer, but for the DHEAS and the ACTH, when we are suspecting mild autonomous cortisol secretion, so that cutoff, how specific is that? Like, I have a patient that has abnormal dexamethasone suppression test, has CKD, we couldn't do a 24-hour urinary cortisol, and then the VA doesn't allow us to do salivary cortisol always. But the DHEAS and the ACTH like go against that. Like the DHEAS was like higher than 100 and the ACTH was higher than 15. So do you think that would be enough, like, to rule out mild autonomous cortisol secretion, or do you think I should still do a second confirmatory test?
That's a great question. So it has 96% specificity when we see the DHEAS more than 100 and the ACTH more than 15. And I think that still, based on, if I see the patient in the clinic, I will be probably doing another test. And the 24-hour urine collection, and this patient that you mentioned has renal failure, so it's not, the best test. I have seen some patients with mild autonomous hypercortisolism that the 24-hour urine collection is normal, right? So I will evaluate the patient, make sure about like the risk factors that the patient has, as we mentioned in the slides. If this is a patient that has high blood pressure, obesity, a patient that have diabetes, metabolic, bone disease, and then probably do another test on beside the 1 milligram and the DHEAS and the ACTH. So I think that you need, to evaluate well the patient and then make a decision. But it's a really good question. I will do another test.
Thank you, doctor. Yes, he doesn't have any findings concerning for hypercortisolism at all. Actually, he's very skinny, but like Yes, thank you, doctor. I will think what to do. Thank you.
Yeah, and then I mean you can always, if you don't have any clinical manifestations, then you can always repeat laboratories later, right? And a good discussion always with the patient, and more when we are in front of a mild autonomous hypercortisolism and adrenal incidentaloma. So have a good discussion with the patient and what make you feel comfortable, also with what make the patient comfortable, right? If there's no any clinical manifestations, I'll probably then like follow the patient maybe in 6 months, 12 months, and then reevaluate the workup.
Perfect.
Any more questions or comments before we end the meeting? I want to also be respectful to the time of all the attendees and, of course, Dr. Sevilla, who has done such an amazing job today. Thank you.
Thank you. Thank you all for joining the presentation, and also for our amazing endocrine team that they are always very supportive. And I saw that many of them joined the presentation, and thank you also like for all the great comments that you did after my presentation. And I hope that you learn a little bit more about what we already know about adrenal incidentalomas.
Thank you.